Viktor, we talked earlier about obviously the curative intent setting and how we, if we can offer a curative option, we try to for our patients. Tell us a little bit about immunotherapy moving into the locally advanced setting. What's going on there?
Well, I think there are also plenty of activities actually trying to combine radiotherapy and curative radiochemotherapy with immunotherapy. And I think this is a very interesting setting because considering all the preclinical data that really suggests that there is a tremendous benefit that we deliver at least to mice for now, but we would like to do it in men. And so I think, yeah, and I think that's part of it. I mean, so of the clinical trial reality that we have already, and it's not as easy as we think. I think with the data from ESMO, combination with ipilimumab, cetuximab, radiotherapy, there's some toxicity, so you could not, there's a certain dose level you should not cross then with ipilimumab. So there are some safety hints that it may be not a piece of cake to get through radiotherapy, and maybe cetuximab might not be the optimal partner. I wouldn't be surprised if that would be one answer. So, but I think it really has a lot of promise combining radiochemotherapy with immunotherapy, and it could be a future way on how we succeed to treat early forms of localized disease and this cancer.
Yeah, and we alluded earlier to how they may cooperate mechanistically. Mm-hmm. And Kevin, I don't know if you can help shed a little bit of light on how radiation and checkpoint blockade may interplay.
Yes, I think that this is a huge potential area, and to my mind, as a radiation oncologist, I see this as something that we're really obliged to do for our patients, because of course it's fantastic to have drugs that work in second-line relapse metastatic or first-line relapse metastatic setting, but what I want and what the patients want is they want to be cured at the time they first present with their disease, so they never have treatment in relapse metastatic setting. So as far as radiation is concerned, we know that radiation under certain circumstances, and these are extremely rare, can itself act almost like an in situ vaccination and lead to distant responses, so-called abscopal responses. I've seen those very, very seldom in my career thus far. The idea behind combining checkpoint inhibition and radiation is perhaps we could use that confluence of the two different mechanisms to make abscopal responses more predictable and also more effective at a distant site. And of course, the idea of bringing these therapies together and engendering an immunologically relevant and immunogenic cell death by radiation would allow us not to treat macroscopic metastatic disease, but better still at the time of first treatment to get rid of micrometastatic disease that may subsequently lead to metastatic failure. But of course, if you control that at the time of first diagnosis, the patient is cured. They never have to go through these first and second line regimens.
Yeah, and then, yeah, Tanguy, I was going to turn to you to talk about the interplay between chemotherapy and checkpoint. Yeah. And of course, you're leading one of the major trials in that area.
Yeah, I mean, I think one additional comment that I would like to make is that, disease burden might be important for immunotherapy, and maybe a good thing to explore is actually when we have minimal disease, minimal residual disease, or very small amounts of disease. So maybe in the adjuvant setting, there's an additional opportunity. And so we're leading a multi-center study in the adjuvant setting with pembrolizumab. There's a study through, I believe, ECOG ongoing with nivolumab. So I think that may be an additional opportunity where maybe checkpoint inhibition is the most effective when you have small amounts of disease. With respect to the combination with chemotherapy or testing it versus chemotherapy, I think there's something intriguing with chemotherapy. So we only have data in actually other diseases, in lung cancer, but consistently in multiple diseases, adding chemotherapy to checkpoint inhibition seems to increase response rates, like above the chemotherapy threshold. It seems to make also progression-free survival longer, and we are actually seeing data in lung cancer from the KEYNOTE-21 study here at the ESMO 2016 meeting. And ultimately, clinically, it makes a lot of sense. So I think Viktor briefly alluded to that. If you have a checkpoint inhibitor, some patients may not benefit, and we actually don't know these patients, but giving them chemotherapy might buy us time. So it's almost like a pharmacodynamic effect where we have more time for the immunotherapy to work, and maybe also make the immune system more strong and expose antigens, very similar to what Kevin said with radiation. So I think, unlike a lot of people who had concerns about combining chemotherapy with immunotherapy, so chemo with immunotherapy, it seems actually to work quite well, and we have one trial in head and neck cancer that would be KEYNOTE-48. Again, I think we have to wait for those data. I would not do this outside of a clinical trial. The same is true for radiation. I think there's a lot of question marks about those combinations. This has to be done as part of a clinical trial, and there's always a balance, toxicities, maybe immunosuppressive effects. So I think doing this as part of trials is really essential.
Yeah, so a lot of exciting data that have emerged. I think we're all very excited about what's to come over the next few years. This has been an extremely informative session, but before we end the discussion, I'd like to get everyone's final thoughts from each of the panelists. Dr. Grünwald, some final comments?
I think it's a very exciting time, actually. So I think after really decades of lack of progression, actually, in the field of head and neck cancer, we really make some advances, and it really is great to see these active therapies coming to clinic, and all those opportunities that suddenly just blossom in front of our face, actually, in all those clinical trials. Yeah. So I think the future is bright. I agree.
Dr. Harrington?
So I would have to echo Viktor's comments. Absolutely. It's a fantastic time to be working in the field of head and neck cancer oncology. I think the message that I'd like to give really is to patients that there is real cause for optimism from them as well, in that there is real opportunity for benefit for all of the modalities that are used to treat them, so surgically, radiotherapeutically, and with drug development. And indeed, with the new wave, this fourth limb of the anti-cancer armamentarium, immunotherapy, we've really got something that could have an interaction with all three of those treatments. So you can perceive the potential for adjuvant therapy post-surgery, combinations with radiation therapy, and then either replacement of chemotherapy or addition to chemotherapy to yield benefits. So I think we're going to see huge benefits in the next 5 to 10 years, and will completely change the way we treat this disease.
And Dr. Seiwert?
Yeah, well, I completely echo the notions from my colleagues that it's an exciting time for head and neck cancer. A lot is happening. It's an exciting time because of immunotherapy. And so the one thing I would like to add is immunotherapy already is a standard of care now for head and neck cancer, and I believe that we'll see tremendous progress over the next 5-10 years. And I think it behooves us to do this as part of clinical trials. There's great opportunities, and that's what I think we should do. We should learn and get better.
Yeah, it's really an amazing time to be in the field, and I think we're privileged to be at the precipice of some really remarkable changes. So I want to thank all of you. I want to thank our panelists for the contribution to this wonderful discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.